Hello, I am Dr. Sanjay Marathe, child specialist from Nagpur. Today we are going to discuss prevention of rabies in this rabies mission. As we all know, rabies is a viral zoonosis which is transmitted by licks, cuts or licking of mucous membrane or broken skin. It's acute viral encephalitis caused by the neurotropic virus. Friends, it has got almost near 100% mortality, but at the same time it's a preventable disease. Very commonly it is said, once you have it, you had it. In the world there are only 6 cases which are considered to be cured of this disease. Human to human transmission is almost not seen except in tissue and organ transplants including cornea. Worldwide there are about 61,000 deaths reported, and very unfortunately to say, India contributes almost 35%, that is 20,000 deaths reported from India. In India, rabies is not a notifiable disease, and because of that, I am sure lot of underreporting is taking place. So friends, rabies is not only very lethal and 100% mortality, but it is 100% preventable. The WHO has set a target that by 2030, there will not be a single case of dog related rabies death, and for that all of us will have to work very hard. If I am not wrong, the rabies is seen all over the world, but again unfortunate to say, Asia and Africa, they are having the maximum number of cases. There are no cases of rabies in Antarctica and Andaman Nicobar. Almost every year more than 15 million people are getting this post exposure prophylaxis, and that is one of the reasons why we have prevented thousands of deaths of rabies because of this post-exposure prophylaxis. Friends, now it is very important that children are at the highest risk. Why? If you will see, almost 30 to 60% of the cases are less than 15 years of age group. So a very important group for us which should be prevented by giving a post-exposure or a pre-exposure prophylaxis. Why they are at the risk? The kids will always play with the animals, but then even after a bite they will never report it to the family members. Because of their height, the dogs will attack them, will have multiple injuries, and an important areas like head, neck, face is very commonly affected, because of which they can get a serious rabies and a mortality. They cannot protect themselves, they cannot run away, and that is one of the reasons why a pediatric population is always at a risk of getting rabies and a higher as compared to the others. The WHO has categorize these wounds into category 1, category 2 and category 3. Let's see what is category 1, 2, 3. Category 1 is feeding of animals, touching of animals or holding the animal where there is no treatment is required. Category 2 where nibbling or cuts or scratches without the bleeding. The treatment is anti-rabies vaccine and wound care or wound hygiene unless the patient is immunocompromised. In category 3, leaks on mucous membrane, leaking on the broken skin, or there is a direct injury where there is oozing of the blood, where you require anti-rabies vaccine, you require immunoglobulin and most important wound hygiene. Now let us see what is category 3 exposure. As we have seen, 90% of the wounds are category 3 exposure, category 3 bites. This could be a single, this could be a multiple, there is always oozing of blood or leaking of mucous membrane or a leaking on the broken skin. Exposure to bats, especially in the western country. In India, the bat exposure is not considered as an indication to give vaccine. Now there are 3 important pillars for the management or to offer a prophylaxis, and all 3 are equally important. One is wound hygiene, another is anti-rabies vaccine, and third is as immunoglobulins, that is rabies immunoglobulin. Let's see one by one. Wound hygiene is very, very important, and almost 50% of the viral load can be removed if I can give a good wound hygiene. What is this wound hygiene? As soon as the patient comes to you, you must clean this with the soap water. Then you should have a flushing of the wounds for about 10 to 15 minutes under the tap water. Then you can clean the wound with the antiseptic. You can use betadine, you can use iodine, or you can use 70% alcohol. The suturing of the wound is usually avoided unless it's a big wound. Then you can give a loose sutures, especially after giving or infiltrating the rabies immunoglobulin, monoclonal or polyclonal. In anti-rabies vaccine, there are major changes. All of us know what we are following is anti-rabies vaccines. The brain tissue vaccines have already been deleted from the use, and now what the vaccines which are available for the anti-rabies vaccines are purified cell embryo vaccine or human diploid cell culture or cheek embryo. All these three are approved by the WHO. What are the major changes which have come in the position paper 2018 rabies? Now the intradermal vaccine is as good as intramuscular, rather a shade better than intramuscular. Vaccine manufacturers have strongly recommended that they can allow the use of the same vaccine for intradermal use. They are not only equally effective, it is cheap and it is less expensive. What are the sites which are preferred for the intradermal? You can use deltoid, you can use anterolateral aspect of the thigh, or you can use suprascapular regions. And you should never give intra in the gluteal region. What are the points to remember when you are giving anti-rabies vaccine? When you have to give more than 2 doses of intradermal or intramuscular, you select 2 sites like 2 deltoid, 2 aspects of anterolateral aspects of thigh or a suprascapular region. Once you have opened a vial for intradermal use, you have to maintain the cold chain and you have to use it in 6 to 8 hours. Then if by any chance the person has missed the schedule, you have to just go to the near to the schedule, but you have to never restart it. So you have to continue it, but you do not have to restart it. Then once you have to shift it from intradermal to intramuscular, you can shift from the schedule from intramuscular to intradermal or vice versa, but then subsequently you will have to follow the same schedule which to whom you have shifted out. Prophylaxis completed in 3 months. Then if there is a dog bite, you do not have to give either vaccine or immunoglobulin to that child. This is a major change. There is no role of intramuscular immunoglobulin, which was an initial concept of 50% around the local wound infiltration and 50% intramuscular. Now WHO has very clearly said whatever amount of immunoglobulin you have to give has to be infiltrated around the wound. If you can observe a cat or any animal or a dog for 10 days and if nothing has happened to the animal, you can subsequently stop the post-exposure prophylaxis and you can convert this and use this time and convert it into pre-exposure prophylaxis by which the child is protected against the rabies vaccine subsequently. Another important thing which has come, that there is no need of giving post-exposure prophylaxis on consumption of a milk of an animal who has been bitten by a rabid animal or that animal is suspected rabid animal. Now let us see, as we all of us know, category wise how to give anti-rabies vaccine. In category 1, in an immunocompetent person, in category 1, nothing is required except the wound hygiene if there is a wound or if there is a leaking of the intact skin, you have to just clean it with the soap water. In category 2, in an immunocompetent person, there is no role of giving rabies immunoglobulins, but you have to give anti-rabies vaccine. As all of us know, the standard IPCR recommended schedule was 5 dose 0, 3, 7, 14 and 28. That has also been recommended by WHO. Now they have reduced the number of doses and they have given more than 1 dose at a particular day, and there is adequate data to support that by reducing the number of doses or duration, it has not compromised the quality and duration of protection. The another dose schedule which they have suggested, that on day 0, you give 2 doses of intramuscular at 2 different sites and 1 dose on day 7 and 3rd dose on day 21. So this is a 4 dose schedule which is recommended by IPCR in their recent recommendations of 2019. If you are using intradermal, then the schedule which they have given, you have to give 2 doses at 2 different sites on day 0, day 3 and day 7. So you can give these 6 doses on 3 days and complete the immunization schedule equally. If you go to category 3, the anti-rabies vaccine schedule remains the same, but then you have to give rabies immunoglobulin, preferably a monoclonal rabies immunoglobulin has to be given, which is now preferred over the rabies immunoglobulin, which we are going to see subsequently. If the patient has already received post-exposure prophylaxis before, or he has been given pre-exposure prophylaxis and now he comes with the history of animal bite, suspected dog bite, rabid dog, then you have to give only 2 doses. Either you can select an intradermal or intramuscular depending upon the availability. You have to give 2 doses as before, 1 dose on day 0, another dose on day 3. If you are giving intradermal, then you have to give 2 doses on day 1 and 2 doses on day 3. Now let's see. Now let's see what is the dose schedule for pre-exposure prophylaxis. If you all know, previously it was recommended that you have to give 3 doses. On day 0, day 7 and third dose was given either on day 21 or day 28. Now the WHO has recently recommended a change in the schedule. What they say, either you can use intradermal or intramuscular. For intramuscular you have to give 1 dose on day 0 and another on day 7. If you are using intradermal, then you have to give 2 sites, that is 2 doses on day 0 and 2 doses on day 7. That is enough to give pre-exposure prophylaxis. Ideally speaking, every child should be given pre-exposure prophylaxis, which has been highly recommended by IPCOI. But if it is not possible, at least the high risk group. Who is the high risk group? All the professionals who are coming in contact with the rabies animals management, like medical professions, the medical staff, the veterinary staff. Not only that, the microbiology people, then the lab technicians who are coming in contact with the samples, they must also take pre-exposure prophylaxis. Another important group is army, policemen, even the postmen. They should also be given the pre-exposure prophylaxis because they are likely to get many animal bites in their services. Third important pillar is an immunoglobulin. Friends, as you know, the incubation period of rabies is usually 3 to 4 weeks, could be in months, could be in years. But sometimes if the lesion is in this near head neck phase, this could be as less as 1 week. And even if I start giving anti-rabies vaccine from day 1, it takes about 10 to 14 days to have an adequate level of antibodies to be achieved, which will protect that individual. So what to do with this gap? So to cover up with this gap, you have to give passive antibodies which will give immediate protection, and that is the reason why in category 3 or immunocompromised patient with category 2 will be given rabies immunoglobulins. Till yesterday, the 2 immunoglobulins were available. One was equine rabies immunoglobulin and second was human rabies immunoglobulin. They have got their own limitations, which we will see. But if I give only immunoglobulins, I am not going to protect the child 100%. If I give anti-rabies vaccine alone, still I am not going to give the protection 100%. So friend, if I have to give 100% protection and I have to follow strictly what category 1, 2, 3 is, I have to use all the 3 important pillars for the 100% protection against the rabies. Now this slide shows what is this gap which is to be filled by giving an rabies immunoglobulins. Now what are the limitations with the equine rabies immunoglobulins or the human rabies immunoglobulins? Basically the limited supply. Cost is not affordable to many of us. Not availability, it is available only at the bigger centers. Then the quality of the rabies immunoglobulin cannot be maintained throughout the year or throughout all the batches. And the biggest risk of anaphylaxis or a blood-borne pathogens can be transmitted through this. And these are the basic limitations. And WHO SAGE committee was working for almost last 30 years and was recommended you must find out some alternative which is a safer and easier and cheaper alternative to this, which is going to give you the 100% protection as good as human rabies immunoglobulins or equine rabies immunoglobulins. So unfortunately what has happened, the human rabies immunoglobulins or equine rabies immunoglobulins are available, or rather they are not available when it is required the most, that is in the periphery or in the rural areas. Now let us see. The rabies immunoglobulins or rabies monoclonal antibodies should be given as soon as possible, but can be given up to 7th day of starting the anti-rabies vaccine. If patient has come even after 20 days with the wound and he has not received an anti-rabies vaccine, still you can give rabies immunoglobulin because you have not started anti-rabies vaccination. The WHO says there is no need to give any skin testing, but if I go by the package insert, you have to go for the skin testing. So to save yourself, a skin testing may be required, but WHO says it is not required because it's a life-saving drug. Then now there is no role of intramuscular rabies immunoglobulin. You have to give whatever dose, you have to infiltrate around the wound. Now just to complete this, what is the doses? If I am using an equine rabies immunoglobulin, the dose is 40 international units per kg. If I am using the human rabies immunoglobulin, the dose is 20 international units per kg. And now a freely available, a safer alternative, a rabies monoclonal antibodies which are available in India freely for last 1 year. The dose is 3.3 international units per kg. This dose has to be infiltrated around the wound if you feel that the wounds are multiple and you will require a larger volume, you can dilute it 3 times into a normal saline and infiltrate. You can use only once. You cannot just go on repeating these Rabies immunoglobulins frequently. Friends, if I go through a WHO 2016 SAGE committee report, there was a strong recommendation to find out the alternative for the Rabies immunoglobulins which were available. And why? Because of what they have seen, that only 10% of the people will receive Rabies immunoglobulin because of its non-availability and cost effect and cost inhibitions, and risk of anaphylaxis was another reason. If I see, the Rabies immunoglobulin is a polyclonal, so which is a non-specific, whereas the monoclonal Rabies antibody has got a very specific action, so it is to be preferred over the polyclonal. Now it is freely available. Rabies monoclonal antibodies are available, which is available as 40 international units per ml and 2.5 ml vial is available. The dose which is to be given is 3.3 international units per kg to be infiltrated around the wound, can be diluted 3 times in normal saline. It has to be stored in 2 to 8 degrees. Do not freeze. Once you have opened it, you have to use it and throw it. You cannot keep it and use it for any other patient subsequently. What are the distinct advantages of the monoclonal Rabies antibodies? It is prepared by recombinant DNA technology, so it is very safe. It is like taking a multiple copies of the same, so quality can be maintained. The quality control is possible. The unlimited supply is possible. The availability is not a problem. Can be supplied to the extreme periphery of this country where it is required the most. The cost effective, it is available for almost 1/3 or 1/4 cost of the human Rabies immunoglobulins. There is no risk of anaphylaxis. Almost there is no risk of anaphylaxis, and there is no risk of transmission of the bloodborne pathogens. So these are all advantages. Then in the phase 3 trial, they have proved that on the day 14, the antibody levels achieved by giving a Rabies monoclonal antibodies versus the human Rabies immunoglobulin, it is almost 4 times more as compared to the human Rabies immunoglobulin. The WHO SAGE committee has strongly recommended, and friends, if I am not wrong, which is based on the satisfactory safety and efficacy results, human Rabies monoclonal antibodies can be effective and can be an effective and safe alternative to blood-derived Rabies immunoglobulins, and hence the DCGI has also approved the use of Rabies monoclonal antibodies in India in 2016. Not only that, friends, if I will see the IAPCUI 2019 recommendations, it has also supported the view of WHO position paper 2018, and it says if available it should be preferred over human Rabies immunoglobulin or equine Rabies immunoglobulin, which is now freely available in country. Friends, what are the important points which are covered in WHO position paper Rabies? Either you vaccinate every animal or especially the dogs to prevent Rabies transmission, or you freely support pre-exposure and post-exposure prophylaxis. Then you can use intradermal as good as intramuscular vaccination schedule, which is very safe and equally effective. Reducing the duration of doses and vaccination schedule is not compromising with the quality and duration of protection. Monoclonal Rabies antibodies should be preferred over Rabies immunoglobulins. There is no role of intramuscular Rabies immunoglobulins or monoclonal Rabies antibodies. After post-exposure prophylaxis, no ARV in next 3 months. If patient has received post-exposure prophylaxis or pre-exposure prophylaxis with the next animal bite, he has to be offered 2 doses, either intradermal or intramuscular, and no role of Rabies immunoglobulins. Now for the professionals, the immune correlate of protection is 0.5 ml, 0.5 international units per ml. If you are offering this vaccination to the professionals, either you have to monitor this level. If any time it is less than 0.5 international units per ml, you have to give a booster. If monitoring is not possible, you can give on an average 1 dose every 5 years to protect the professional from getting it. The post-exposure prophylaxis or a pre-exposure prophylaxis is absolutely safe in lactating mother or in a pregnant mother. An immunocompromised host, you have to follow the CD4 count, and if the CD4 count is less than 200 cells, then in that patient should be considered as unprotected, and even if he is getting multiple animal bites at different times, and if the CD4 count is less than 200, every time you will have to give anti-rabies vaccine, wound hygiene, as well as the anti-rabies immunoglobulins. Friends, in summary, I can say rabies is near 100% fatal, yet 100% preventable disease if we follow the categories very carefully and give the treatment accordingly. Thank you.